All right, good morning, everybody, and thank you for being here so early. I wanted to take kind of a fresh perspective on the treatment of embolization in CLI patients. I think this is definitely under-recognized, under-reported. And if you look at different trials, remember the trials that were conducted, they were conducted on a less sick population that we see in real life practice. So I want you to keep that in mind. So if you look at the body of evidence out there, it says that the numbers are not that high, and I'm not suggesting that they're significantly higher, but predictors of distal embolization and peripheral percutaneous interventions, if you look at any registry, the predictors are long lesions, less frequency of chronic onset, and lower TIMI flow. The things that you see and kind of raise the alarm whenever you look at the angiographic pictures, right? And you can actually see that the same risk factors kind of highlight themselves into other registries and other large cohort patients trials, looking at what are the things that are more predictive of the possibility of embolization or clinically significant embolization. And again, if you look at, if you compare both groups in terms of technical failure, technical success, amputation, mortality, obviously the patients that have embolization, they tend to have worse outcomes for patients. So in order for me to kind of prove a point, I want to show you one of the case. People think of thrombectomy as situations that are acute limb ischemia, so on and so forth, and obviously it's important in those situations. But in the universe of advanced PAD and critical limb ischemia, it's more common than what you think, and I'm going to show a case here, hopefully, to drive that point across. So a 67-year-old male with 4 weeks history of worsening wound. Risk factors include, the typical risk factors for CLI patients. And the patient had prior stenting in the right lower extremity for claudication, and the details to me were unknown. When I met this patient, I did not know. And this is a diagnostic angiogram that you see on the left, and on the right you see the ultrasound images, superficial femoral artery, popliteal artery. There is no flow in certain segments of a popliteal artery. But this is a diagnostic angiogram there, and if a lot of us do this kind of work, and whenever you see this angiogram, the conversation changes from, did you see the game last night, to like, quiet, turn off the music, and let's focus on what's going on here. So you automatically see that there's occlusion, but then you see filling defects. That's before you even done anything, before you looked at the patient, before you treated the patient, before you decided to do anything. This is a patient that walked into my office the week before with a wound on the foot, Rutherford class 5, and having rest pain, right? So, and it did not start within 24 hours. It's been progressive for weeks, and this is the angiogram that you see. So, talk about a bad day. We can spend a long time discussing this case. We have a very, very distinguished panel here. What can you do, and so on and so forth. But everything you move on from here is trying to touch everything in a very cautious fashion. So the goal was to create a distal embolic protection device, create embolic protection there. I already see that there is embolization that happened already. And I don't think it's from me. I think it's embolization that happened onto this patient from before. Well, treatment strategy, is it fibroelastic atheroma? Is it covered stents? Whenever we say thrombectomy, everybody assumes that this is fresh thrombus, but there's also macro debris, right? So especially if you have a covered stent, and I think this patient had a covered stent, self-expanding covered stent from before. So you have thrombotic fibrous material. There is no aneurysm. This is something that you always have to think about when you see distal embolization and closure of the tibial vessels. And the challenges with these atheromas or macro debris is difficult to, it's not just, you suck it out and you're done. It's more bulky, it's more clingy, and it does a very nice job shutting down the vessels down the road. So what should I treat? Things to consider: embolic protection, anticoagulation, plantar circulation, revascularization modality, tibial protection, and access points. So this case, I did not use the Pounce device. It was not available to me at that time. And I'm just showing you that despite me trying to follow all of those things, the only difference here, I already accessed the posterior tibial artery expecting that this is going to happen. I was up and over in this patient. The patient height is about 6 foot, so I knew I'm going to have issues with devices. I have 3 tibial vessels, already have embolization, and the situation is going to get worse. So I'm already worried about all of those things with this patient. So, and even though I just placed an embolic protection device beyond at the reconstitution site, I already see that thrombus has moved to the what we call for cardiologists, the left main of the lower extremity, which is a trifurcation of the AT, TPT, PT, and perineal. So we had a 7 French sheath. I started doing manual thrombectomy or plaque removal. I chose laser because of Phillips laser atherectomy. I was not able to reach all the way, but I knew this is going to happen, so I had access in the posterior tibial artery. And this is an extravascular ultrasound image of a posterior tibial artery, and you don't want to see this. This is the last thing you want to see on a patient. I laugh now. I was not laughing at that time. But I was glad that I placed the sheath because the sheath was able to trap that debris, and I had to place a catheter and perform manual thrombectomy in a retrograde fashion for this patient. So overall, I did not have an ideal result. I removed as much of the debris as I can. I was able to reestablish blood flow after doing retrograde manual thrombectomy for this patient. Complex situation. By the way, I would also, maybe it's a controversial, it'll be interesting for the panel, but like I don't even think that just placing this patient on lytics overnight or doing all of that is going to resolve the situation, because like I said, I don't think this is just simply thrombus. I think this is macro debris, elastic material, very challenging. But ultimately, I was able to establish blood flow for the posterior tibial artery to the foot, despite everything that happened. So even though it's clinically significant distal embolization, relatively rare, it has been associated with worse outcomes, and I suspect it's underreported, especially with the patient population that we treat. And the point of this case was, we're always reactive when things happen. We're always reactive to embolization, despite everything that we do. So how about preventive strategy versus reactive strategy? And I think that's a nice segue into, the Pounce device, where we go in, and when you see a lesion like this, where it's not only thrombus, but even macro debris, and you think the risk of embolization is high, and if you saw the live cases yesterday, there are predictors of that issue. We have Pounce LB, the Pounce, and the Pounce XL. They're all 7 French sheets. This is the intended use of a device to basically, it's a non-surgical way to remove the thrombi and the emboli from the peripheral arterial vasculature. And we have 2 vascular surgeons here. They're going to talk about that concept. This is a video basically showing the mechanism of action for this device, and I think it's a proprietary, the fact that they have 2 distal capturing filters, one to initially trap most of the material, and the second one I feel like it's a cleaning after into the funnel proximally. And there are different sizes, different diameters for the Pounce system, anywhere from 2 millimeters to 10 millimeters, and it works in different locations, in the upper extremities, in the lower extremities, and I think that's very important. So the fact that it's 7 French actually is pretty good. I would like for the engineers of the Surmodics to think about maybe the 018 system, lowering it down to 5 French or to 6 French, but that's my wish list. And as I said, it works in different locations depending on where it is. The XL, it's color marked, so you can see that the Pounce XL 5.5 to 10 millimeters, the Pounce is 3.5 to 6 millimeters, and the Pounce LP, which is more for distal vessels like the tibials, 2 to 4 millimeters. And this is the platform. It's very clear fluoroscopically, so you're not struggling to visualize it. You're not struggling to see it. There is no capital equipment that you need. It's basically out of a box. You can utilize it, and you'll be able to remove most of the debris in one setting. And you can actually apply it multiple times depending on how much do you need to do it.